We were talking about the spinal cord. We're still talking about it. And we talked about the spinal meninges starting from pia, arachnoid, and dura. Pia is the innermost, as a reminder, and arachnoid is in the middle, and dura is the outermost. This is like the undershirt, the shirt, and the jacket. Obviously, the jacket is durable. And why is that? Because remember, the spinal cord and the brain, both of them are located inside the bone, right? So the outermost is the one that's facing the bone. It has to be durable enough, right? That's why dura is the outermost, durable. While the pia, which is translated as delicate, it should be the one that's in direct contact with the spinal cord. So in between these meninges, there are spaces, like this space between my shirt and undershirt, right? Between my jacket and my shirt. There are different spaces, and each one of these spaces has its own significance that you have to know, okay? So beside the arrangement, what are the spaces and what are the importance of each space? Um, just know that these together, pia, arachnoid, and dura, are called the meninges. And if it got infected, we call it meningitis. Do you guys remember when I talked about the spinal tab that we do it between 2 and 3, between L2? Why? Ends at between L1 and L2. Spinal cord and between L1 and L2, right? So if I wanted to insert a needle, I would go under 2, after 2, between 2, 3, or 3 and 4. So this is for meningitis. It is an infection of the meninges. It can be bacterial or viral. The only way to know that for sure is to get a spinal tap. If you look at this picture here, you will see the 3 meninges. This yellow here is the pia, and then the arachnoids, and the outermost is the dura. As you see here, it's yellow, light blue, and then purplish blue, kind of. These are the 3 layers, and there are spaces in between that we will talk about. So look at this picture right here, and we have in the lab, we have a model that looks like this. So if you look from inside, this is the spinal cord in the middle with the gray matter, looks like an H shaped, surrounded by the white matter. And you guys remember the PSAF, PSAF? Posterior sulcus and anterior fissure. So you see the sulcus here, and look at the fissure. What's the difference? This is the sulcus, and this is the fissure. The fissure is deeper. So when you see the fissure, know that this is the anterior aspect. Surrounding and adherent to the spinal cord is pia, which is this one right here. Then you have a space, and you have arachnoids. What's the name of that space? The space under the arachnoid. So we call it subarachnoid space. Significance, CSF. This is where the CSF circulates. So remember the spinal tab that I talked about? This is where we go. So we insert the needle, passing the dura, passing the arachnoid, stop. That will take you to that space, and then we get a sample of the CSF. So this is the significance of that subarachnoid space. Then you have this arachnoid space, dura. What's the name of that space? Under the dura, subdural. Nothing important about that. Just know that it's called subdural. Last one is outside of the dura, which is epidural space. Do you see the yellow? This yellow here? Remember, I told you guys several times that in the pictures and in the models, any yellow lobular structure means fat. This is always how we do it. So this is basically a space that contains fat. Why? To act as a cushion. We have a lot of things to protect the spinal cord being very fragile and very soft, just like the jello-like. So we have to protect it in many different ways. This is one of them. Surrounding it around in this space with fat, this will act as a cushion. So if the spinal cord move, this will absorb the shock. So what's the significance or the importance of the epidural space? And each one of those is obviously a question. And that's why I'm focusing on it. Okay, what is the importance of that space? Number one, it contains the fat, the epidural fat, which is for acting as a cushion. The other thing is, ladies know that when you deliver a baby, they give you the option of epidural anesthesia. Did you hear about this? Anybody have babies? Do you know this? The epidural anesthesia. This is an option that they give you if you wanted to have painless delivery. They insert into that specific location. So they insert anesthesia into this space where we have the fat. This is called epidural anesthesia. So the importance here is contain the fat plus epidural anesthesia. We go to that space. These are the importance of those two. PIA itself, beside being the innermost, beside being adherent to the spinal cord, the blood vessels run along its surface. And this is significant. Each one of those is an important piece of information for a question. If you put these together, you can get a lot of questions. I'm telling you, okay? The significance of each one of those is important. It's a question. What's the importance of the epidural space? What's the importance of the subarachnoid space? What is the significance of the pia mater beside being the innermost? Blood vessels run along the surface. So here it is, dura mater, the outermost, the toughest, and epidural space. I talked about it, containing the adipose tissue, and this is a location for anesthesia. Subdural space, nothing much. Arachnoid is the middle layer. Underneath it, subarachnoid space containing CSF, and this is the lumbar puncture, also known as spinal tap. And specifically, you have to go under L2 to get it. But which space do you go to? If you wanted to get a sample, subarachnoid space. Why? It contains the CSF. So this is where we get that sample from. Pia mater is the innermost one. And look at this, blood vessels run on its surface. This is the importance of this pia mater besides being the innermost one. Another thing here, remember, we have to make sure that the spinal cord, which is jello-like, yes, to that extent. When we do gross anatomy in medical school, like if you push it with your finger, you're going to break it down. It's very fragile, like jello-like. So you have to make sure that this is protected and fixed at the same time. You shouldn't allow much movement because when you move, if it hits something, it can break down very easy. So one of these things is the denticulate ligament. This is a ligament that anchor the pia mater to the dura mater. It starts from the pia mater inside and go across like this until you get into the dura mater. So look at this. If this is the spinal cord, surrounded by pia mater, protection, space, subarachnoid space containing the CSF, act as a cushion, extra protection, subdural space, dura, another protection, right? Epidural space, act as a cushion, all of this surrounding it, but still not enough. You want to make sure that it doesn't flip like this. Okay, if it flip, it can hit something, right? For extra protection and to prevent it from doing this, we are going to do two things to prevent it from flipping like this. Number one, denticulate ligament that I just talked about. This is the spinal cord, and let's say this yellow here is the pia mater, right? I'm gonna get pairs of ligaments, one pair segment. So one will be going like this and like this. 1, 2, 1, 2. Each segment will have these denticulate ligament starting from the pia and going to the dura. Now it's not flipping, right? Still not enough. Look at the end here. What do you call this end? If you guys are studying with me. This end of the spinal cord, what do we call it? What does it look like? Looks like a cone. No, the end. The horse tail is after that. But this cone-shaped end looks like a cone, so we call it conus medullaris. Okay? So in order to make sure it's even more stabilized, there is a film or a tendon, a ligament, I mean, start from here and go all the way to the coccyx. What is the name of that film? Starting from the tip, go to the coccyx in order to prevent flipping. What is it? I gave you part of it. Film. Film. What is it? Filum terminale. A film at the terminal end of this cone. It goes from here and it's actually stretched down all the way to fix it to the coccyx. Did you get the idea? So now it cannot flip. All of this surrounding it, including denticulate ligament, including the filum terminal. And where does the filum terminal start and end? Tip of the cone, which is the last point of the spinal cord, and goes all the way down, stretching down to the coccyx. So if we ask you, you should know this. Okay? So if you look at this picture right here, look at this. These are the different roots. This is the posterior root, and this is the anterior root. But can you see this white right here? Can you see this white coming from the pia and going out? Here is one, here is one. This is called denticulate ligament. Here it is, like this, like this. In between each two nerves, there is one denticulate ligament. You will need to identify it when we go to the lab. I talked about the innermost or the core of the spinal cord, which is gray matter. Obviously, it's unmyelinated, and the white is mainly myelinated. It's you can't say it's myelinated. It's not 100%. Mainly myelinated. So there are some unmyelinated, but that's okay. You still call it the white matter. Mainly myelinated. Now, if you look in the inside of the gray matter, we are going to have three horns, posterior, anterior, and lateral. And then connected, the two sides are connected by something called gray commissure, but I prefer to do it from the picture here. So look at this. The dark here is H-shaped gray matter. The outside here is white matter. I'm talking about the gray now. Okay, so in the gray, you see the three horns. Here is one horn, very obvious. And here is one horn, very obvious. And the third one is not very obvious. It's just this little piece here. So posterior horn, anterior horn, lateral horn. Three horns. The posterior horn is where the posterior root comes. And the posterior root carry sensation or motor. I talked about this yesterday. Posterior root. Does it carry sensation or motor? Sensation. And the anterior root, motor. Meaning the sensation enter from here and then the motor exit from here, from the anterior horn. Now look at those three horns and the other three horns. Remember I mentioned bilateral symmetry. Do you remember this? Bilateral symmetry. Right side looks like the left side. The two sides are connected in the middle here by a commissure. A commissure means a connector, commissure. This commissure is called the gray commissure. And look in the middle, you see this white? This is the central canal of the spinal cord. What is this for? Remember the CSF is moving in the subarachnoid space. At certain points, it goes and circulates within the central canal of the spinal cord, and this is the importance of this central canal here. It's a canal at the center of the spinal cord. What should you call it? central canal of the spinal cord for the passage of the CSF. On the other hand, you will see the surrounding, this white here. This is called posterior column or funiculus, lateral column or funiculus, anterior column or funiculus. So it's the same posterior, anterior, and lateral, yes, but the gray matter is horn because it's actual projection, it's horn, but for the white, it's not a horn, it's column or funiculus. Funiculus means column. You will see it. So here is the white matter, posterior column, anterior column, and lateral column. And also there is a connection in between. Look at this. Look, what is this? First of all, let's divide it into two parts from here. Posterior sulcus and anterior fissure. Do you see the fissure and sulcus? Can you recognize them? Look how this is deep. So this is P-safe, P-S-A-F, posterior sulcus, anterior fissure. So if you cut exactly here, you will have this half and this half. Now, look at this one right here, posterior column. Look at this column here, lateral and anterior column, all right? Same thing on the left side. Posterior column, lateral column, anterior column, also known as funiculus. How about the horns of the gray matter? Posterior horn, lateral horn, anterior horn. Now the question is how to know posterior from anterior. Like if this is in the lab, or if I show you a picture like this, how to know anterior from posterior. Like this is a column, this is a column, this is a column. The lateral is lateral, it doesn't change. It's lateral. But how to know anterior from posterior? There are different things. Number one, look at the fissure. P-safe. So the fissure is anterior. This is one. Number two, look at this ganglion. The ganglion is in the dorsal root only. It's called dorsal root ganglion. So this ganglion means this is the dorsal, which is the same as posterior. So those two together will give you the anterior from posterior. This is for orientation purposes. Okay? Here is the dorsal root ganglion. What's a ganglion? What does it mean? Collection of cell bodies. Which neuroglia do it and maintain it? Satellite cells. Yes. Satellite cells. So dorsal root ganglia is right here. This is a dorsal root, also known as posterior. There is no difference. Posterior is dorsal in the back. Anterior, ventral in the front. Okay? So these are the two roots, posterior roots and anterior root. The posterior roots or dorsal roots, does it carry sensation or motor? Sensation. And the anterior is motor. So what happened here is information come from this one, posterior root, it enter in, pass through the gray matter. There might be an interneuron in between, but then the motor command leave through the anterior root. And guess what? Both of them will run together. Both of them will run together. So if I ask you, spinal nerve, is that sensory or motor or mixed? It's mixed because both of them run together. When we do the cranial nerves, the situation is different. Cranial nerves, it can be anything. Sensory alone, motor alone, mixed. But this, mixed. That's it. Only mixed. So what is this horn is? Posterior horn. What's the posterior horn for? It received the sensation, isn't it? Posterior horn receives sensation from the posterior root. Are we following? Are we good? So this is a posterior root, posterior horn, I'm sorry, getting the sensation from the posterior root. Where are you getting it from? Sensation. Sensation can be somatic or autonomic. Are you guys following? Are you getting sensation from skin and muscles, which we call it somatic, or from the viscera? We call it autonomic or visceral. So this one received the somatic and this one receive the visceral. Then when you give a motor command, the motor command for visceral is here at the lateral column, and for somatic is in the anterior column. What do I mean by that? I mean all sensation enter from the dorsal horn. But when it comes to the motor command, they leave from different horns. The visceral motor command leave from the lateral horn. Can we see this blue? You see this blue? This is the lateral horn. So the visceral or autonomic will leave from the lateral horn. And the somatic motor will leave from the anterior horn. Did you get the idea? Like this. We have one door here and we have two doors here, right? Men and women, boys and girls, both of you enter from here. But boys exit from here and girls exit from here. So you both enter from the same, but you exit from two different things, okay? So sensation and motor, both of them enter from here. And then when you exit, somatic and visceral, both of them enter from here. But when you exit, somatic exit from here and visceral exit from here. Did you get the idea? So lateral horn is where autonomic or visceral exit out, while the anterior horn is where the somatic exit out. Now inside the white matter, so the gray matter, we got what's inside. Somatic and visceral sensory in the posterior horn, somatic motor in the anterior horn, and then autonomic motor in the lateral horn. This is the gray matter. How about the surrounding? What do we have here? We have a bunch of tracts. Some tracts are going up, some tracts are going down. That's within the white matter. The ones that are going up are called ascending. You're ascending, going up. The ones that are going down are called descending tracts. Okay? And let me tell you this. Do you guys remember when I said the central nervous system is the manager of the body? But I put it in levels, right? Spinal cord is like a supervisor. Brain is like a manager. Cortex is like the CEO, the highest manager. Remember this? Okay, so if I'm telling you there is a tract that's moving up within the white matter of the spinal cord, moving up from the spinal cord, going up to the brain, do you think this will be carrying sensation or motor command? Why? Because if you work somewhere, do you give information to your manager or you give orders to your manager? Information, can you give orders to your manager? He will fire you, right? You give information to your manager. So if you're going up, you're carrying sensory information to the big boss, right? And who gives orders? The manager gives orders. So the brain gives orders. So anything that's going down, it's carrying a motor command. Is this part clear? So ascending tracts are sensory or motor? Sensory. And descending, motor. Now the nerve itself. When we say nerve, and we are going to learn about the nerves, but when we say nerve, like ulnar nerve, radial nerve, this is a nerve, a complete nerve. Inside this nerve, there are fascicles or bundles. Inside of them, there are several neurons. Do you guys remember the muscles? We did the muscles. Remember this whole entire muscle contained fascicles or bundles, and each one of them contain one of the muscle fibers. Do you remember this? So it's the same idea. And do you guys remember around the muscle, epimysium, surrounding the fascicles, peri? Do you remember this? And endo, same name. But instead of mysium, which is muscle, here we say neurium. So you have epineurium, perineurium, and endoneurium. Isn't it the same? Epi, peri, and endo? It's the same name, but neurium. So epineurium surrounding the whole entire nerve. Perineurium is surrounding bundles or fascicles. Endoneurium, the innermost, carrying what? Surrounding one axon of one neuron. Look at this picture right here. This is the whole entire nerve, surrounded by epineurium. Look at the fascicles inside, or the bundles surrounded by, the fascicles are surrounded by perineurium. Now, if you get one of these nerves, it's surrounded by endoneurium. What if I remove the endoneurium? You will find the axon itself. Okay, so the axon is surrounded by endoneurium. The spinal nerves, how many spinal nerves do we have? Total, 31. How many cervical? 8. Thoracic, lumbar, sacral, coccygeal, 1. You will be asked about this for sure. Lab and lecture. Okay, so don't forget it. So we have 31 pairs of spinal nerves. All of them are mixed, and I mentioned that before. Now, for each one of these sensory nerves, if we say somatic, so you're coming from the skin or the muscles, right? Isn't that somatic sensory? So there is something called dermatome. And dermatome means each one nerve is getting sensation from certain part. That's called dermatome. Derma means skin. Tome means part or section. Okay? Look at this. If I have numbness here, just this part only. You see this? This. If I have numbness here, I will tell you I have an issue with my ulnar nerve. How did you know? Because this is the dermatome. That's the responsibility of the ulnar nerve. So this patch only, this dermatome, is for the ulnar nerve. This is for the medial nerve. If I have something here, radial nerve. These are called dermatomes. So it's not like my whole upper limb, one nerve is seeing it. No, it's not one nerve bringing sensation from the whole upper limb. It's patches. Each patch is one nerve, and we call that dermatome. And this is helpful. I can tell you easily, for myself, for example, I get numbness here. I know I have an issue in my ulnar nerve. It's an ulnar tunnel syndrome. I know there is something right here. It's compressed a little bit at this point here. So I know this is my ulnar nerve. Why? Dermatome. Inflammation of the neuron, of the peripheral neuron, is called peripheral neuropathies. Just the name is good enough. And shingles is viral infection of the nerves that will give you these vesicles. Nothing much to know. Look at these. These are the dermatomes. Of course, this is too much. I just want you to know what dermatome means. This is just look at it to know how it's actually, look how complicated it is. Each piece is innervated by one nerve. This is how the shingles looks like. Did you hear about shingles before? Did you hear about herpes? Shingles is kind of herpes. It is, if you guys are interested only, you know, herpes is a virus that come to the skin first, and then you see that you have like vesicles here or something that's kind of painful, and then it disappears, right? No, the nerve didn't go away. I'm sorry, the virus didn't go away. It just go in the sensory nerve until it find the ganglia. You remember this ganglia? It hide in the ganglia. And you think everything is over. It's not over. Once you get it, it's over. It's there. It will never go away. Just go and hide in the ganglia and wait for the next time when your immunity is a little bit weaker. Like if you have common colds, if you're taking medications, whatever it is. And then it leave the hiding, it's very weak. It leave the hiding spot and go out. And then you see the vesicles again. I got infected again. No, you're not infected again. It's just going out because you're weak. Once you start to regain your immunity, it just hide again. Okay. Same thing for these infections here. Once you get it, you get it. It disappeared. It goes away. No, it's hiding. The virus is hiding. And then at any time, if you're weak, it goes out and go in the skin and give you these painful vesicles known as shingles. Now, if you look at this, It's not as simple as I mentioned before. Remember, I told you the nerve, the spinal nerve, is just like a tree. You have roots, you have trunk, you have branches. The branches are called ramus. A branch is ramus, right? So where are the roots? The roots are here. Which one is this? Can anybody tell me which one is this? Posterior or dorsal? Yes, because of the ganglia, right? Okay, so this is dorsal root with dorsal ganglion. This is the ventral root. This is dorsal root. I mean this. And this is the ventral root right here. Can you see this? They come together. Do you see this little piece right here, exactly here? This is the spinal nerve itself before it gives branches. So the stem or the trunk is a very tiny piece, just this little piece. Can you see how the roots come together, run a little part, and then divide? So just this little piece here is the actual spinal nerve. And then it will give you two main branches. Which one is this? Do you think this is dorsal or ventral? Posterior or anterior? Posterior. It's the same side as the ganglion, isn't it? So this is posterior and this is anterior. This is for the somatic one. But you do have another two rami for the autonomic one. Okay? One of them is called white ramus and the other one is called gray ramus. So do we have two branches only? No, it's four. Two main branches, posterior, anterior. What's a posterior feeds? What does it feed? I mentioned it yesterday. What does it feed? The posterior ramus, the branch in the back. The back muscles. The back muscles. How about the anterior? Everything else. So which one is bigger, anterior or posterior? Anterior, because it's feeding everything else. Okay? So this is for those two, anterior and posterior. These are the main ones. How about those two extras? Yes, this is for the autonomic. So there is a white ramus that goes into this ganglion, which is called the sympathetic ganglion, and another one that goes back. So you have to communicate with this ganglion. Now I want you to remember which is which. There is one white and one gray, connecting the spinal nerve to the ganglion. Which is which? To remember it, the white ramus, the white branch, is the one that goes to the ganglion. And the gray is the one that's coming back. To remember it, and this is how I remember it. You go to the ganglion and you are white, clean. And then when you do the work in the ganglion and coming back, now you are gray. You're not white anymore, okay? Like you're going clean, everything is clean. You're wearing a white shirt, okay? And you're working around. By the time you're done, it will get dusty, right? It's not white anymore, it's gray. So the one that goes to the ganglion is white. The one that returns is the gray horn, the gray ramus, I'm sorry. Look at these. These are the two rami. One of them is the white ramus, which is this, going to the ganglion, and this is the gray that's coming back. And then the continuation after that, it will go to the different organs. Now, the nerves, the spinal nerves, the 31 spinal nerves. Are we following? 31 spinal nerves. Is each one of those nerves just go like from here all the way? No, not all of them. The ones in the thoracic region are the ones that just continue parallel like this. One nerve comes from one segment in the thoracic region and runs all the way. Others, they come together to make a network, a plexus. So we have four plexuses that are very important. The nerves do not run parallel from the beginning to the end, only in the thoracic region. Anywhere else, they make a plexus to communicate and coordinate. Clear? How many plexuses do we have? Four plexuses. Very important. One in the cervix, which is the neck, cervical plexus. One close to the brachium, brachial plexus. One in the lumbar region and one in the sacral region. Four of them. Look at this. This is the cervical plexus here, this one. This is brachial, going to the brachium. This is the lumbar, going to the lumbar region. And this is sacral, going to the sacral region. A lot of times, instead of saying lumbar and sacral, they call it lumbosacral. Lumbar and sacral plexuses, or you can call it lumbosacral together, okay? Depending on the question that you will see. What do you want us to know about this very important part? I have 4 plexuses. Each plexus, I want you to know the roots. Where does it come from? Specifically, not generally speaking. Specifically. This is 1. Number 2, I want you to know the main nerves that come from the plexus. So it's like this. The nerves, spinal nerves are coming like this, and they merge. They come together, not merging. They make a network, okay? What's after the network? There are nerves that continue to the different body parts. Clear? Do we need to know all these nerves? Not all of them. Some of them I will give you the names that you have to know. But first of all, I want you to know the origin of each one of those. It's 1, 5. Here is my mnemonic. You don't have to use it. This is what I do. 1551 12444. The way I memorize it back in medical school, I say 1551 12444. If you memorize this sentence, 1551 12444, this will give you the origin of all 4 plexuses. You got like 3, 4 questions just in this sentence. 1551 12444. What does it mean? C1 to C5, cervical plexus. C5 to T1, lumbar. Brachial. T12 to L4, lumbar. L4 to S4, this is sacral. You cannot be confused. Like this is 12. 12 what? Is it lumbar? Is it sacral? Is it which one? Which is the only one that we have 12? Thoracic. This has to be T, right? So T12 to L4, L4, L5. Do you notice the repeat? Like 1551. What do you mean? I mean 5 is sharing in both of them. 5 is sharing in both plexuses. How about this? 12, 4, 4, 4. Yes, it means that L4 sharing on both of them. Is that clear? The root is very important. You will be asked about it. And this is why I put it in this way. I remember it 30 years ago. Okay? I still remember. Just because I memorized this. 1551 12 4 4 4. That's it. Yes. Yes. Can you memorize this? I don't think it's too hard. 1551 12 4 4 4. This will give you the origin of all 4 plexuses. Okay. Now, from each one of those, there are a lot of nerves that come out, but there are specific things that I want you to remember, which are the most important. What are the most important? From the cervical plexus, I want you only to remember phrenic nerve. Phrenic nerve. There are other nerves, I understand, but minimum is phrenic nerve. And I want you also to remember that phrenic nerve feeds the diaphragm. How to remember it? Phrenic phragm. Doesn't it rhyme? Doesn't it sound similar? The phrenic feeds the diaphragm. Okay? By the way, all what I'm giving you now is what I used to learn when I was in the medical school. Okay? Otherwise, it's a lot of information. Okay? You have to find a way to memorize. So phrenic phragm. Phrenic nerve feed the diaphragm. This is the one nerve from the cervical plexus. There are others, but this is good enough to know. Brachial plexus is the only one that I want you to know all the branches. We have a lot of information to know. 3 out of the 4, I will be specific. I give you 1 or 2 only. Okay? But for the brachial, no. You have to know all of it. Everything in the brachial plexus. Because this is the most important one. And for the brachial plexus, look at this picture right here. It will give you everything. First of all, the level of the roots. What are the roots from here? C5 to T1, right? Okay, so here is C5, C6, C7, C8, T1. Clear? Next level. 5 and 6 come together to make superior trunk. 7 alone will make middle trunk. C8, T1 will make the inferior trunk. Clear? This is the next level, the trunk level. And then they are going to branch. The trunk is going to branch. Okay? Like these branches, superficial and deep branches. Superficial and deep branches. So this is the next level right here, which is called the division. Superficial and deep divisions. Roots, trunks, divisions. I got you 3 levels so far. Clear? Next level is the chords. This one here is the lateral cord. This is the medial cord. And this is the posterior cord. Ah, you're saying medial and lateral. Why don't you say like middle? Medial, lateral, middle. No, it goes like this. Look at this. It starts like this, okay? Superior, middle, and inferior. All right? For this? Okay, when you move down, you're moving like this. Look. So this will become what? Medial. And this will become lateral. And look at this, it goes to the back like this. So that's why I don't call it middle. I call it what? Posterior. Did you get it? So there is medial cord, lateral cord, and this is not middle. It is posterior because it actually moved backward. So these are the cord level. Medial cord, lateral cord, posterior cord. Branches. Branches from the medial cord, ulnar nerve. You see this nerve? Ulnar nerve. Branch from the lateral cord, musculocutaneous nerve. What's musculocutaneous? Musculo means muscle, cutaneous means skin. They found a nerve feeding these muscles and this skin. What should we call it? Musculoskeletal. Are we following? From the medial, I get the ulnar. From the lateral, I get the musculocutaneous. From both of them, medial nerve. Medial cord, ulnar. Lateral cord, musculocutaneous. And there is one nerve that get roots from both of them, from both medial and lateral, and this is called the median nerve, which is this one right here. Can we see this M shape look? Like this and like this? You see the M shape? So the M shape is musculocutaneous, ulnar, and in the middle, median. And that's why they call it median, because it's in the middle. Did you get 3 nerves so far? There are another 2. Come from the posterior cord, and these are radial nerve and axillary nerve. Okay? And this is for the brachial plexus. This is the one that you need to know all 5 nerves. Okay. More details is not needed. Okay, unless if you're interested to read. But I do want you to know what I just mentioned. The 5 stages, including the nerves. One thing that they noticed here, which is the median nerve that goes in the middle, it runs in this, there is a tunnel here. Do you guys remember how the bones looks like, the carpal bones? Some of them are like protruding like this. So in order for the nerve to reach the hand, it has to go in between these carpal bones. Those two that are projecting like this, there is kind of a tunnel in between. And they call it the carpal tunnel. Did you hear about carpal tunnel syndrome? This is what it means. There is a tunnel because those carpal bones are protruding like this, and actually there's a connection. It's covered. Something called flexor retinaculum here. So that creates a tunnel in which the median nerve has to go. And in some people, for whatever reason, this tunnel can get a little bit tighter and it can compress on the median nerve, and this is called carpal tunnel syndrome. Look at this. You will not be asked about this. This is too much, but just see how interesting this is. This is the ulnar nerve. I was telling you guys that I do have some issue in my ulnar nerve because of this. Why the numbness is coming here, right? At the red. I know it's the ulnar nerve. So this is, again, this is just the dermatomes. Lumbar plexus, which is 12 to 4. The nerves that I want you to know here is femoral nerve, obturator nerve. But femoral nerve is the most important. Femoral nerve. You have a lot of nerves, right? I want you to pay attention to the most important and the biggest one, the largest, femoral nerve. Okay, so if you forgot, if you don't remember, you cannot forget from the lumbar plexus, femoral nerve. From the cervical plexus, phrenic nerve. From the brachial plexus, I have 5, right? Ulnar, from the medial, musculocutaneous from the lateral, median, both of them. And then from the posterior, I have 2, radial and axillary. This is 5. So cervical, just 1 nerve, phrenic. Brachial plexus, I have 5, and I talked about it. Now the lumbar, femoral. You cannot forget it. How about the sacral plexus? Sacral plexus, I want 2. Sciatic and pudendal nerve. Sciatic and pudendal nerve. These are the ones that you have to remember. Sciatic will end up giving you the fibular nerve and the tibial nerve, which is tibia and fibula. But the minimum to know is these 2 branches. Are we familiar with the sciatic nerve? Did you hear about it before? This is the longest nerve in the whole entire body. Do you guys remember the bones when we did this greater and lesser sciatic notches? Does anybody remember this? The sciatic nerve goes in and out in those 2, and guess what? It come from here and go all the way to your big toe. It's that long, like all the way from the pelvic bone right here, running in the back of your thigh, running in the back of your leg, and even go in the sole of your foot until it goes all the way to your big toe. And if you hear about sciatica, especially it's more on pregnant ladies. Do you hear about it? You get sciatica temporarily and then it goes away. Because in pregnant ladies, the baby or the fetus can be pushing on the nerve. Okay, so it goes away after birth. But if it is inflamed, it's called sciatica. And they simply say, I have a shooting pain starting from here in the back and the buttocks region and goes all the way to my big toe. I feel like burning sensation that's in this whole area. So this is sciatica. Sciatica is inflammation or compression. Doesn't have to be inflammation. Like in pregnant ladies, there is no real inflammation. It's compression. So sciatica, sciatic nerve. And to remember it, the S goes with the S. Sacral sciatic, plus pudendal nerve. So you have 2 nerves to remember in this part. Look at the sacral plexus. The largest one here is the sciatic, and beside it is the pudendal nerve right here. Look how big the sciatic nerve is. Look, starting from here, going all the way down until the big toe. Yes, it gives branches, tibial and fibular, but it's an extension from the nerve. This is again the dermatomes. Now the neural pool. Remember that we have sensory neurons, and we have motor neurons, and we have mixed. Remember this? The thing here is how these neurons are, sorry, thank you. How these neurons coordinate with each other, how they link to each other. We call that the neural pool. So according to the relationships between the different neurons, the pools can be divergent, convergent, serial, parallel, and reverberation. I would rather see it in the picture. Look at this. Look at the blue neuron, and it feeds two other neurons. What do you think this is? If this is convergence or divergence or parallel or what? What do you think? Does it diverge or converge? Diverge. So this is divergence. 1 give 2, and maybe 2 give 4. Isn't this is diversion? How about this? 1, 2, 3, 4 feeds into 1. What do you think? Conversion. So many neurons feed into 1, the opposite of divergence. Next is serial processing. Serial processing is simply 1 after 1 after 1 after 1. That's it. Very simple. Parallel is if 1 give more than 1, but these ones do not divide anymore. They run parallel to each other all the way until the organ. So this is parallel processing. Last one is reverberation. What's a reverberation? Here is a reverberation. It looks like the serial processing, which is nerve. Look at the blue. A nerve, give another nerve, give another nerve. So you would say this is serial processing. Doesn't it look like the serial processing? Look at this. 1, give 1, give 1, right? It looks the same. So what's the difference? Here is the difference. It is nerve number 1, go to one nerve only. Nerve number 2, go to one nerve only. Number 3, it's not divergence, it's not convergence, it's not parallel. So it's serial processing. No. What's the difference here is when one nerve go to the next nerve is going to go back and stimulate the previous nerve. So 1, go to 2, go to 3. Yes, but 2 is going to activate 1. And 1, go to 2, go to 3. And then 2 will activate 1. You continue to reverberation. And this happen only if you want a continuous contraction or something. Like if you're standing up and you want to stand up, you have to keep your muscles contracting, right? So 1, go to 2, go to 3, and 3 go to the muscles to contract. If that's it, you're going to relax. I don't want to relax. 2, reverberate to 1. And 1, give 2, give 3, give the muscle, you continue to contract. And then 2, reverberate to 1, contract. 2, reverberate to 1, and so on. So this is called reverberation or positive feedback. Okay, you started the contraction and you continue the contraction by reverberating. Neural reflexes. I talked about the reflexes before, but it's not that simple. There are a little bit more details. Do you remember the reflex? What's the start? Between touching and moving. What's the first thing? Receptor, followed by sensory, or also called known as, what's a sensory? Other name for sensory. Afferent, and then you go in the central nervous system. You might have an interneuron, and then what's the one that exits? Efferent, or, and then it goes to the, and the muscle is called what? Effector. Yes, effector. Is that clear? Receptor, afferent or sensory, coordination center or control center, which is the central nervous system, efferent or motor, effector. Is that clear? These are the components of the reflex. Not that simple. We have different reflexes to learn. So the reflex consists of receptor, sensory, processing in the central nervous system, motor or efferent, until you get to the effector, right? So this is what you do. Look at this. Here is one of the reflexes. If you step on something, or if you put your hand on the table and there is a nail or something, or your foot, whatever it is, what happened here? Receptors pick up the signal, the red. This is sensory or motor? What do you think? The red, sensory. And what is this? What's the full name? It is a ganglion. What's the full name? Dorsal root ganglion. This is the dorsal root, isn't it? Isn't the dorsal root is the afferent, is the sensory? Are we following? Dorsal root ganglion. And now you enter from what? From the posterior or dorsal horn. You have the nucleus here. Do you remember the nucleus for somatic and visceral? I showed you that, remember? So, okay, so you stop here at this nucleus. Do you see there is white and then black? So if there is white, the white is an interneuron. If there is an interneuron, this is called polysynaptic reflex. What's poly? Many. Many means more than one. How many synapses here? Red to white, this is one. White to black, this is one. Isn't this is more than one? You call it polysynaptic reflex. What if I don't have this white and just go red, black? What do you call it? Monosynaptic. Clear? Now the question is, why sometimes we have interneuron and this will make it polysynaptic and sometimes we don't? So we call it mono. Why sometimes yes, sometimes no? Why? Because if this is something that's very simple, it doesn't need any coordination, nothing. If that's the case, you just need to do a reflex, right? Sensation, motor command. That's it. But if you need any coordination, or if you wanted to keep a memory, you have to have an interneuron inside your spinal cord in this case. If you have this third one here, this or the interneuron, it's going to help you with number one, coordination. Like in this case, and I will show you coordination. Number two, you need to let the brain know. Look where this is going. This is like when you say a secret is between two people only, right? If there is a third one, it's not a secret anymore. So afferent, efferent, that's it. Nobody else know. But if you have a third one, it will let everybody know. I'm talking about the brain, basically. It will let the brain know. It's not a secret anymore. It will let the brain know so that you keep a memory. If you touch an oven or a stove and it's hot and you move away, next time, even before you touch it, don't you know that it is hot and I'm not going to touch it? How did you know? Interneuron. Keep a memory for you. Okay? Is that it? No, there is also coordination. And what do I mean by coordination is this. The simple reflex, did you see the neurologist when they do the neurological examination? Did you ever see that hammer that they hit here and you move like this? This is monosynaptic. There's nothing that you need to do because you're sitting, right? Hit, move. That's it. No coordination needed. You don't do anything. Just you move like this, right? This is a simple reflex, monosynaptic. But think about it if you're walking and your right foot step on a nail. You want to move your right foot, right? That's not it. Because if you do that, you're going to fall. What else are you going to do besides moving your right leg away? You have to contract the left leg and make sure it's fully extended. Otherwise, you're going to fall, right? Think about it. How did the left know? If it is only monosynaptic, it's polysynaptic. Who is going to tell the left to coordinate? It's the interneuron. Did you understand this? Is that clear? So if I step on something, not only that I want to move it away, no, that's not enough. You're going to fall. You don't fall because the left one is going to contract. How did the left know? Interneuron. So the interneuron is serving two purposes. Number one, letting the brain know, memory. Number two, coordination. So we're going to divide the reflexes as follow. Number one, from the time of development. Is that something that you're born with? Yes, you are born with some reflexes. Or is it something that you learned, you acquired, innate or acquired? Motor responses, what do you do? Do you move away? Do you move closer? What do you do? Complexity, is it simple or complex? Is it mono or poly? Plus the site of information processing. So the first one is innate. This is something that you're born with. Acquired is something that you learned later on. And innate is something that you're born with. This is like withdrawal, chewing, and visual tracking. Let's say withdrawal. If this is a baby, just a baby, if he touched something, he will move away. Okay? He doesn't need to learn it. You're born with it. Chewing. 1 day old newborn. He know how to chew, right? He can get the milk and swallow it, right? So he's born with it. So this is called innate reflex. Can he actually? Yes. Did you see that? A 1 day old, he can get the milk and he can swallow it, right? Without issues. It means he's born with it. And this is innate reflex. Acquired is something that's need repetition to learn. Braking the car in emergency. If I get you and this is your first time ever to drive a car and there's another car coming, do you know how to brake, how to use the brake? You don't even know what is the location of the brake, right? And you don't know how to do it. You have to learn, like if it is far away, I'm going to push the brake a little bit. If it is close, I can push it more. Isn't this is something that need learning? Right? So these are acquired reflexes, something that you learned later on. And in order to learn it, it needs repetition. The next one is what kind of motor response? How do you respond to that reflex? Is it a somatic reflex like this? You touch something, you move away. What kind of reflex is this? Who is the effector here? Can you tell me? If I do this, move away. What's the effector? Who did the job? These muscles, right? Isn't these are skeletal muscles? Skeletal muscles, isn't it? So this is a somatic reflex because the muscle that do the job is a skeletal muscle, voluntary, so it is somatic. Okay? If the reflex is something else that's not somatic muscles, we call it visceral or autonomic reflex. Example, somebody surprised you all of a sudden, or all of a sudden you heard a loud noise. Don't you see your heart speeding up, right? What kind of reflex is that? Tell me who is the effector, and I will tell you what kind of reflex. Obviously, the effector here is the heart. Is that skeletal muscle? The heart is it skeletal muscle? Then it's not somatic. It's autonomic reflex. So who is the effector that will tell me what kind of reflex? Is that clear? If the effector that's doing the job is a skeletal muscle, I call it somatic reflex. Otherwise, it's called visceral. Anything else, not necessarily the heart, anything else that's part of the viscera uh, will be a visceral reflex. Complexity, I just gave you example. Is it simple monosynaptic or it's complex polysynaptic? Mono or poly? Some of them are monosynaptic and some of them are polysynaptic. Example of the monosynaptic that you need to know. Knee jerk. What's a knee jerk? This is the neurologist hitting you at the patellar tendon with a hammer and you just move. You move your leg like this. This is monosynaptic. Polysynaptic is something that's more complicated. It needs more coordination. And I give you example like withdrawal reflex. You hit something and you move your leg away. Okay, you cannot do that without coordination. So this will be polysynaptic. And polysynaptic can be more complicated. Look at this. If this is the spinal cord, something like this, and here is somatic or afferent posterior, and then anterior come from here. Is that monosynaptic or polysynaptic? How many synapses? This is one and this is one. So synapses is in between. It's one synapse, right? This is monosynaptic. So this is like the knee jerk. Okay. If I have another nerve here, like you step on something, this one ends here, another one starts, and another one starts from here. How many synapses do you see? Two. So this is mono or poly? Polysynaptic. It can get more complicated than that if what we're talking about so far is which segment are we talking about. Let's say this is L4. Okay? Everything here is L4. Afferent or sensory, interneuron, and efferent or motor. All of this in the same level. It can be more complicated than that if the muscle that you wanted to contract is in another level. So you can send another neuron up to go to L3, for example. What do you call this? Intersegmental. L4 is a segment. Do you guys remember the 31 segments? If all what you're talking about is in the same segment, afferent to L4, interneuron L4, efferent L4. This is in the same segment. If you need to go up or down to involve another segment because you want to involve another neuron or another nerve, we call that intersegmental, which is a little bit more complicated. Okay? Intersegmental. If you wanted to involve another segment. Now, site of information processing. What's information processing? Information processing is a function of the manager, right? Who is processing the information and give you the motor command? Either the spinal cord or the brain. Agree? Who is coordinating? It is the spinal cord or the brain. If the spinal cord is the one that's coordinating, we call it spinal reflex. If the brain is coordinating, we call it cranial reflex. Spinal reflex, I gave you several examples, like you touch something and you move away, withdrawal reflex. Knee jerk, this is a spinal. I can give you example of the cranial reflex. If I move something close to your eyes, what automatically going to happen? If I'm barely touching, it's going to close, right? Who gave the order to your eyes to close? Your brain, not the spinal cord, right? This signal go to the brain and the brain tell you to close your eyes. So this is called cranial reflex because the site of processing here is the brain. So here it is. We can classify it in different ways. It can be innate and acquired, and you do need to know an example of each one of those, and I mentioned it already. Innate reflexes or acquired, somatic or visceral. Somatic, if your effector is the skeletal muscles. Visceral, if it is not the skeletal muscles, smooth or cardiac. Complexity, mono or poly. Poly, it can be intersegmental. processing site. It can be spinal, it can be cranial, depending on where is the site or where is the location of processing, spinal cord or the brain. Here is the example that I talked about. Monosynaptic. What's the example? Stretch reflex or patellar reflex or the knee jerk that I talked about. Okay, you have to know this. Monosynaptic. Give me example. Stretch or patellar reflex. This is a knee jerk. When we hit with the hammer, you're going to move your leg like this. So this is the example. And obviously what's happening here is muscle is stretched. You know what happened here if I hit this tendon? If I hit it, this quadriceps is going to stretch. There are receptors inside my muscles that are going to be stimulated. Afferent, processing, efferent, muscles contraction. Look at this. Here is a hammer hitting this patellar tendon. The quadriceps muscle is going to stretch. The receptors inside these muscles are going to be stimulated. And by the way, receptors here are called muscle spindle. I want you to remember this name. What are the receptors that help us with the stretch reflex? Muscle spindles. It's in the muscles. Simply, it looks like a spindle shaped in the muscle. What should I call it? Muscle spindles. Okay? Is that monosynaptic or polysynaptic? Monosynaptic. Red, black. That's it. There is one synapse. So this is an example of the stretch reflex, of the monosynaptic stretch reflex. Okay? Here are the muscle spindles inside the muscles. Postural reflex. Postural reflex is most of the time it's monosynaptic, but sometimes it can be polysynaptic. And the postural reflex is the reflex that keep you upright like this. Like if I'm standing up or sitting down, even if I'm doing like this. Why I don't like relax like this? Can you stand up and continue to stand up? Do you know what's happening when you're doing this? At any time, if you started to relax, a reflex will come and make you contract again. And that's why you don't fall. Whenever are you going to fall if you're standing up? If you fall asleep while standing up, right? What's the animal that sleep standing up? Horse. The horse, they actually sleep while standing up. Can you sleep standing up? You're going to fall because the reflex, push reflex fails, right? As long as you're concentrating, standing up, I can continue to stand up. How? Do you think about it? It's happening just as simple as this? No. What's actually happening is when you stand up for a minute, your muscles will start to get a little bit tired. But once you start to bend, you don't feel it. But once you start to bend a little bit, the muscles in the back will be stretched. Muscle spindles will be stimulated, afferent, reflex, efferent, contract again. Clear? Postural reflex. Most of the time it's mono, but it can be poly. For polysynaptic, tendon reflex, withdrawal reflex, and cross extensor reflex. You have to remember these examples. Tendon reflex is a reflex that help you not to overstretch the muscles. Withdrawal reflex is this. Touch, hot, move away. This is polysynaptic. How to remember this is polysynaptic? When I do it, do I remember it? If you touch something and move away, do you remember that this was something hot? Since you have a memory, it means you have an interneuron. Clear? If you don't have an interneuron, you will not remember it. Clear? Is that clear? If you are deeply sleeping and somebody hit your tendon, you will not remember it, which is the knee jerk, okay? Or the stretch reflex. But withdrawal reflex, definitely you will remember it, okay? Now the question is, why this is polysynaptic coordination? What kind of coordination? It depends. Here is an example. I touch something hot, I move away by contracting this muscle. Are we following? Okay, still, why this is complex? Why do I need an interneuron? Just for the memory? No, memory and coordination. What kind of coordination in this case? Look, when I do this, contract, this muscle is contracting, but this muscle has to relax, right? Can you contract both of them? You're not moving away, right? If I try to move away and both muscles are contracting, how can I move, right? In order to contract this, you have to relax the antagonist. Aren't you coordinating with another muscle? So this is called reciprocal inhibition. When you contract a muscle, you inhibit the antagonist. The antagonist is called reciprocal. Is reciprocal inhibition clear in this example? You inhibit the reciprocal. You inhibit the antagonist. Clear? Is that clear? So this is for the withdrawal reflex, and that's why it is complex. It's not simple. It's polysynaptic. Two reasons. You have a memory and you coordinate with another muscle. It has to be complex, and you have to have polysynaptic. Here it is. Look, touch something, it's hot, you move away. Not that simple. You contract your biceps, but you have to relax the triceps in this case. That's why withdrawal reflex is polysynaptic. Ipsilateral and contralateral. What does it mean? Your body is two halves, right side and left side, right? If something and everything happening on the same side, I call it ipsilateral. Like if I have my right arm affected and my right limb affected, I call it ipsilateral. Ipsilateral. Like I have pain in my upper limb and pain in my right lower limb, both of them right. I would say I have ipsilateral pain. Got it? Both of them in the same side, ipsilateral. But what if I tell you that I have pain in my right upper limb and pain in my left lower limb? You call that contralateral. Is that clear? Ipsilateral, contralateral. Same side, opposite side. Okay? So ipsilateral reflex is this. Look, touch, move. Did I involve the left side at all in anything? This is ipsilateral. But if I step on something, right? If I step on something, I move it away and I contract the other side. Just think about it. If you step on something, what happened to you? Aren't you moving? I step on something with my right foot. Aren't you moving the right upper limb away? Don't you have to extend and contract your left side, otherwise you fall, right? Think about it. So are you involving the contralateral, the left side, even though the affected side is the right side, isn't it? So this is called contralateral. In this case, it's specifically called cross extensor. What's cross? Cross, like I have an issue in my right side and I'm crossing to the left. Okay? So if that's the case, the interneuron need to cross to the other side. Did you get the idea? Afferent, interneuron, efferent. If all of them in the same side, that's not crossed. That's ipsilateral. Clear? What if I step with my right foot on something? I'm going to move away my right foot. Yes. But you have to contract your left leg as well, right? So the interneuron need to cross to the other side. We call it crossed extensor reflex, and this is maintained by reverberating. Do you remember the reverberating or not? Reverberating, what is it? Is it serial? Close to serial, but what's the difference? Nerve number 2, reverb to 1. And then contract your muscles, reverb, contract, reverb. And that's how you don't fall. Because as long as you're bending one side, you have to keep on contracting the left side with the reverberating. Did we get a practical example of this reverberating serial? Did you get it? It's completely different than the serial. The serial is you go one way, you contract and relax. That's it. But reverberating, you keep on contracting. Look at this here. You step on something painful with your right foot, and you need to move your right foot away, your right limb. You need to move it away, but guess what? You have to contract the left side. You have to extend it in order not to fail. And look at this. Do you see the crossing of the interneuron? Look at the white. Doesn't it cross to the other side? Crossed extensor reflex. So polysynaptic neuron, it involves interneurons, usually more than one segment. Usually you do reciprocal inhibition that I talked about. You use a reverberating circuit, and the reflexes coordinate with each other. These are the criteria of the spinal reflex. These spinal reflexes are the spinal reflexes, the one that has the spinal cord as a processing center. This is under the influence of the brain. Everything is under the influence of the brain. Okay? I'll give you an example. If you're just forgetting about it completely and you are breathing, right? Aren't you breathing automatically? If I'm talking to you and you completely forget about it, you're still breathing, right? Can I stop breathing? Yes. If you ask me, stop breathing. Here it is. Stop breathing. But the breathing was automatic. Yes, the brain has an upper hand. I can influence. Can I speed up? Yes. Here it is, right? How did I do that? Even though the breathing is happening automatically, even if you're sleeping, aren't you breathing? It means it's automated, right? How did I influence? Yes, the brain can influence these spinal reflexes. Here's another example. If you touch something hot, can I keep on touching it? If I want to, I can. Like those people playing like karate or other things, they get like actually kind of hot sand and they put their hand and you have to like voluntarily keep it. Did you ever see that before? This is part of their training. They give them like sand that's kind of hot, not horrible, but kind of hot, and you put your hand and you have to keep it to strengthen this skin. They do it. Okay? So it means you're putting your hand in a hot sand, and they will ask you keep it, don't withdraw. So does this mean that the brain has an influence, an upper hand? Yes, you can influence. You can I move even stronger like this? If I touch something, I move away. Can I move even faster? Yes, if I decided to, right? So you can facilitate or inhibit the spinal reflexes by the brain. Reinforcement versus inhibition of the spinal reflex. We're almost done. Plantar reflex. What's a plantar reflex? Plantar reflex, do we know the planta of your foot? Which side of the plantar region or the plantar surface? The under surface, right? That's touching the floor, right? If I get something and I go like this, touching it like this, you are going to move like this. If I touch, you go like this. And this is normal. Another one, so plantar reflex is normal in adults. Clear? Any one of us, if I touch you like this, you're going to spread automatically. This is a reflex. There is another reflex that happen in infants only and then it disappear. You don't have it. You can't have it. Even children don't have it. If you do, there is an issue. There is something wrong. Look at this. This is the plantar reflex. If I move like this, you're going to do this. Babinski is infants. If you touch them, they will do like this. So if I do like this in the middle like this, you're going to do this. Okay? Clear? Children, if I do like this, they are good. Not children, actually, infants. You're going to do this. What if any one of us, I do like this, and you're doing like the infants, like Babinski sign? There is an issue in your brain. We don't have to go into the details, but it means there is some sort of something wrong in the nervous system. We shouldn't have it. It's not normal to have it. And this is the last slide.